But I want to pivot to something else, and I'm going to be a bit provocative here. So we all experience this. I think it's pretty easy to understand how we can move to driving out variance when we're doing things in the adjuvant setting. But case in point, young person, 30 years old, comes in with their 3-year-old on their lap, and I'm purposely making this a bit dramatic. They have metastatic sarcoma. You gave them whatever the standard of care du jour is. It doesn't work because it doesn't work. You have the privilege of sending off their tumor specimen for next-gen sequencing. The insurance company pays for it, gladly. You get a positive signal. It says an mTOR inhibitor might work here. And now you want to give the mTOR inhibitor. Of course, it's not FDA approved for that, and the payer won't pay for it, and the patient can't afford to pay for it themselves. What do? What should an oncologist do? What should payers be doing with this now that we are in this new generation? We would never do this if this were an infection and we got back a sensitivity report and it said, this antibiotic works and this antibiotic doesn't work. These are FDA approved drugs, so it's not that it's an experimental drug. It just has not been FDA approved for that indication, nor will it ever be. So Mike, I'll start with you.
Yeah, I think the big challenge for payers is trying to sort out what's legitimate and what's not. And we're not in the exam room with you, and God knows we don't. So there is this illusion and that payers, they just love saying no. So no is a problem for a payer. No is expensive. It's a lot easier to say yes, right? No is expensive because people get mad at you, because you got to do an appeal. And yes is a way better answer. So the question is, how do we get to yes? And I would propose to you that if we could develop a methodology by which we actually collected information about those one-offs, we would not only improve care for all patients with cancer, but we would make the no-yes dichotomy a heck of a lot easier for payers. Now, CancerLink, global CancerLink, theoretically will do that. But of course, ASCO has other proposals, something called TAPER, and then Palmetto has put something together called MedC. Opportunities by which information is collected in a registry, rules for futility are determined, and I think, I will speak for myself, I think it's a wonderful idea. I spent some time with the Cystic Fibrosis Foundation because they have arguably the best clinical registry in all of American medicine. And they have used that as a process improvement tool, an accreditation tool, and of course they have fueled a lot of the incredible molecular research in CF. And we need something like that in oncology really bad. I mean, we need to get that information, and then if 15 patients have been treated with this mutation, with this thing, and it works in 8 of them, that should be good enough to pay for it, I think. That's me talking, not the health plan talking. But I think this whole idea of how we use that real-world evidence to affect regulatory and then affect coverage policy is something that we really need to start looking at. Because I think the idea of just one-off saying yes, that's really problematic for the health plan. But I think...
So I think that your scenario was a softball. I think that really the answer that Mike gave is the correct one, that you say this is a very rare cancer, a very rare circumstance, and you've done this test and it demonstrates that it may work, and you say, yes, we will pay for it as long as that data gets into a registry, that we learn from it. You know, 97% of the care that we give, we learn nothing from as far as outcomes or what happens to it. A much more difficult one is that same patient who has now had 3 therapies and they haven't responded to them, and I have a 4th one I want to give them because I did that NGS and there were 4 drugs that might work. It's not just that we have better therapies, it's that we have more therapies. And we have to be judicious in when we use a therapy and when it's time to say, it doesn't make sense to do this.
But I'm glad you said that, because I've been part of this dialogue and I struggle with this. To me, it's the ultimate moral dilemma, that when the physician is outside of the room and they're in the dialogue that you just discussed, which is the futility dialogue and the sense of we have an obligation as citizens, and physicians to not waste the precious resources of our government and increase spending so insurance is unaffordable and we're not competitive and all of those things. But then you walk in that room and all of that changes because your moral obligation is to that individual. So you and I both know that that fourth drug might work, and there's nothing to tell you it will or it won't today.
But it's my moral obligation to be honest with that patient too.
No, of course.
And to go in and tell the patient, yes, this drug may work, but it's going to work in 2% of the time, and here's the toxicities. And if you told me what's the thing that's going to get me the most time with my family for the rest of my life, it's not to take this drug.
You know, I'll differ with you on that because I understand the argument, but I don't know that factually you can say what you just said. Statistically, you're right, but on the individual basis, you may not be right. So the whole idea here is we're moving so fast to understanding what will work and what won't work. It's not the same as it was 5 years ago or 10 years ago. So the question is that how do we do this? How do we, as practicing physicians, not so much a payer, but as practicing physicians, where do we draw the line? I'm not saying I have an answer, but it is not an easy question to answer.
No, it's not.
No, and I think we draw the line in shared decision making. There was a presentation yesterday that compared did an economic analysis of 2 regimens for colon cancer, first-line therapy, metastatic colon cancer, and showed that one regimen of the 2 regimens had equal efficacy on quality of life surveys and every other way you could measure it. They had equal, though somewhat different toxicities. And one of them was twice as expensive as the other one. And at the end, the presenter said, in my patients, I give X. And bells went off in my head. She shouldn't be going in to her patient and saying, I'm giving you X. She should be going into her patient and say, there are these 2 regimens. They have equal efficacy. They have similar toxicities. Here's the toxicities. And this one costs half as much, and that's the one I would like to give you. Is that okay? Until we have those kind of conversations with our patients, we are still practicing paternalistic medicine, whether we're doing it on the basis of this is my favorite regimen or on the basis of cost or whatever reason.
So the nuance of what you just described, when it gets translated to the public, it's a cautionary note because we have to be careful because I know exactly what you're saying. I don't think any of us disagree that if you have equipotent regimens and one costs twice as much, you shouldn't give the more expensive one. In fact, when we were youngsters walking around with our little antibiotic handbook and we were learning medicine, they actually then added a cost sheet.
Yeah.
So you would use the less expensive antibiotics, and this goes back 25, 30 years. So there's no doubt that's going to happen. But separate and distinct from that is when you have drugs, and there's a couple of programs, I think Novartis is starting one and a couple other companies are starting one. If you can have a signal and they have a drug, they may even provide the drug for free.
Yep.
And I think what you said is a potential solution, that if we could get a number of payers to say, okay, we're going to commit to a common registry, and that if you have some level of evidence, not a phase 3 prospective randomized trial, which is never going to happen and take too long, that might be a good thing.
There's an alternative, and this would require, I think, it may actually require legislation. The alternative would be that if someone has a very rare tumor or a very rare mutation, but there is a signal that that there would be a value-based reimbursement model in which the drug is provided for the first month or 2 free of charge, and if it works, then it's reimbursed, and then if it's not, then it's not.
Yes.
So it's interesting because I had a discussion yesterday with a pharmaceutical company asking me if I thought that was something that we would be interested in going forward with. And, you know, so I can't speak for the health plan, but as an oncologist, I think that's dandy, man. I'd love that approach. That would be great, right?
As long as the registry requirement is included with
Absolutely,
it at the same time.
totally agree. We got to learn something about it. And I think, you know, so the people who spend a lot of time doing this, you know, Dane Dixon and Rich Shilsky have been thinking a lot about how to craft this. I think they also want to craft it in a fashion that does not negatively impact research, right? So you want to make sure that however you build this is compatible with however clinical trial development evolves, because I think we can come to a general agreement that the idea of a 3,000 patient study to show a 4% difference with 2 chemotherapies, them days is over.
Yes.
And thank God, because we'd get into arguments about whether it's clinically significant or statistically significant. But I think evolution of clinical trials should occur in parallel with whatever reimbursement reform there are for these type of, we'll call them N of 1 experiments, but they're not really N of 1, right? I mean, N of 1 kind of paralyzes you because you don't know what the heck to do, right? You really want an N of just enough to know what to do, right?
Right, exactly.
So I think that's really exciting, and if we could actually pull something like that off in our lifetime, we have advanced oncology tremendously.
Yes, I agree. So let's shift.